Good morning. My name is Mary Paul Stewart, and I have the pleasure of welcoming you to Virginia Mason Grand Rounds. And I'm going to introduce this morning's speaker, Dr. Eric Varley. Dr. Varley is an orthopedic spine surgeon specializing in complex conditions of the cervical, thoracic, and lumbar spine. He earned his degree at Nova Southeastern University College of Osteopathic Medicine in Fort Lauderdale. His residency in orthopedic surgery was at University of Michigan Metro Health Hospital in Grand Rapids, Michigan, and his fellowship in complex and minimally invasive spine surgery was at the San Diego Spine Foundation. The title of his presentation today is The Intersection, Behavioral Economics and Clinical Decision Making. May I present Dr. Varley?
Well, thank you, and thank you all so much for being here, both live and virtually. I really do appreciate it. The topic of my talk today is the intersection of behavioral economics and clinical decision making. I have no relative disclosures for this topic. So what are we going to go through today? I'm going to talk a little bit about humans versus Homo economicus, and you'll see what I mean in just a minute by that term. Go into framing, break that down into how it leads into prospect theory, which is a theory that's kind of the cornerstone of behavioral economics. Talk about loss aversion and sunk costs, another facet of prospect theory, and then break it down into heuristics and biases. And with the heuristics and biases, the goal isn't necessary to go through an exhaustive list, but more touch on some of the ones that are interrelated that maybe we aren't all aware of that affect us as providers. And then we'll wrap it up at the end. And I'd encourage you, in this talk, I've got a handful of questions scattered throughout it. I just ask as you're watching this, this isn't going to be a raise of hands or anything like that, but if you can just think about a few of them and think of how you would answer them, I think it would add a little something to this talk for everybody listening to it and kind of illuminate, give you a little self-reflection on how our own biases work. So with that in mind, Homo sapiens versus Homo economicus. So Homo economicus assumes that an individual makes rational choices based on optimal outcomes. They're able to do complex deductions, choosing from a myriad of possible decisions with the idea of maximizing value, or in economic terms, they use the word utility. So we use our rational minds focused on what is giving us the maximal utility, weighing the pros and cons in a logical sort of means. And this has really been a core principle of economic theory, and I would argue medical education for years. I mean, this is a text dating back to the late 19th century, and again, just assumes that we make rational choices based on a rational analysis of the risks, the benefits, and then we optimize based on that information. And a good example of this is breaking it down into the axioms of what they think of as rational choice. And just two of them I think that are relatively useful. One is transitivity. And so what that says, if I like A more than B and B more than C, well, then logic would dictate I would like A more than C. So if I like beer more than wine, but I like wine more than a cocktail, logically I should like beer more than a cocktail. But that's not always how we function. Another axiom of rational choice is expected utility theory. Again, utility in the context of this talk will largely be synonymous for value. And it describes assumptions of decision making. And again, it assumes the rational human being is going to make a choice based on an assessment of the risks and benefits of each choice. So an organizing principle of behavioral economics and kind of the stuff I've been talking about it is that it covers two different theories, right? Rational, or should I say expected utility theory, should be both normative and descriptive. And when I say normative, it tells you the right way to think. And I don't mean that in a moral way, but rather it tells you that you are thinking in a logical, consistent way under varying conditions. And in our example as physicians, both patients and ourselves make choices to, again, maximize benefits and minimize risks. And we do it in a consistent way. So that's normative theory. It should also line up with descriptive theory, which is what we actually do. It describes our actual behavior. So a rational human being would be thinking about things consistently, and the choices they made would line up with the actual choices that would be predicted. And so I've got a preteen in geometry, so I figured I'd throw this question up here, and it's just a good example. So let's say we have two train tracks. Each is a mile long. We nail down either end, and they're joined in the middle. Each track grows and expands by 1 inch. How much does it buckle in the middle? Okay, now you don't have to answer that, but just a little interesting thought experiment. So the answer, the average that people guessed, and this is from some of the work by Richard Thaler, who put this in his excellent book, Misbehaving, the average guess is 2 inches. So that's what the average is. That's what consistently this question generates. But in reality, the actual answer is 28 feet. So it just kind of shows you a little bit of how we can have our normative theory, but that doesn't always line up with the descriptive theory. And this is kind of a mathematical example of that. So let's boil this down a little deeper into some of the things that we kind of see in clinic. This is a vignette or a vignette where a disease outbreak affecting 600 people breaks out. Which treatment would you choose? I'd call your attention to this top row. So in this first example, treatment A, 200 people are going to be saved. Treatment B, there's a 1/3 chance of saving all 600 patients, but a 2/3 chance of saving no one. Which do you pick, option A and option B? Well, when this was presented in Tversky and Kahneman's 1981 paper in Science, 72% of people said option A. I mean, we don't want to not save 200 people. And so then they asked the question in a slightly different way. So look at this second row right down here. Same exact clinical scenario. In this example, 400 people will die with treatment A. Treatment B, there's a 1/3 of a chance nobody's going to die, and 2/3 of a chance that all 600 people will die. Which one do you choose? Again, what the authors published, 78% of people chose option B. So, this is an example of how you answer that question is largely based on how that question is framed, either in a positive or negative connotation. And so if you break that out and blow that out in terms of framing, in a positive framing, people don't want to lose 200 people, and they're not willing to take the risk on treatment B. That's what makes sense, because we do risk taking to avoid losses. However, in a negative frame, you want to avoid 400 people dying, so let's take the risk on option B, because we're risk averse to achieve rewards. And it's something that you see again and again and again as you go through this literature, which is interesting. So in framing, risk perception is different in loss versus gain, and that people derive less psychological value from gains than we necessarily do for losses. And this is very well demonstrated by frozen yogurt. Contains 20% fat or 80% fat-free. What sounds a little more appealing for those of us that are health conscious? And so human beings, Homo sapiens, I don't know if Homo economicus really describes this, because that describes a rational species that makes rational decisions that are predictable and consistent. Rather, I think there's a fair degree of evidence that we're largely irrational, and that irrationality is somewhat predictable. So that concept leads to prospect theory. So prospect theory was initially published by Danny Kahneman and Amos Tversky in 1979. You'll hear these names throughout the talk. They're Nobel laureates and really kind of the godfathers of behavioral economics. And so what they said under prospect theory is it's a descriptive theory. Remember, descriptive talks about what we actually do, decision making under uncertainty. And what they noted, and what we just described from one of their experiments, is that losses and gains are perceived differently, and that our decision-making process is not based on necessarily maximizing utility value, but rather our decisions are made based on relative gains and losses. So how much of a change it is between what we gain and what we lose, not necessarily on what the absolute value or outcome is. And this is really demonstrated nicely in this very famous chart or graph of theirs. And what you can see here is on the y-axis, we have value going from down here from negative to positive. And on the x-axis, we've got losses on this side and gains on this side. And so what we can see for the losses, or excuse me, for the gains, we like gains. If you gained 200 of this relative unit, the value is 250. But as much as we like gains, we hate losses even more. So if you lose 200, you see that the relative value feels like 400. And that's a good way of describing loss aversion. And this is also a good way of looking at this chart. We wanted to avoid those losses of life. And that skewed the way that most people see those numbers. So related to loss aversion is a concept called sunk costs. And these are costs that have already been incurred and cannot be removed. And what it really describes is a continued suboptimal course of action as we keep betting more and more and more and more. As we double down, we continue to pursue this sunk cost to avoid a loss. And a good example is this case 1 and 2. And essentially what case 1 says is if you buy a ticket and you lose a ticket, would you buy another one? Would you spend another $10 on that same ticket? In this scenario, and you can read it above right here, in this scenario, 46% of respondents said yes, 54% said no. In case 2, rather than losing the ticket, you lose the $10 bill. Would you go in and pay another $10 for the ticket? And interestingly, in this scenario, 88% of people said yes, 12% of people said no. And mentally, you're like, well, but that doesn't make any sense. You've lost $10 no matter what, correct? But that just goes to show you how we perceive losses versus gains. And this was nice to describe in another one of Kahneman's papers published in American Psychology in 1984. So prospect theory and what I've described to you leads into the concept of heuristics. And heuristics are just a way of describing that we make choices not based necessarily on a rational assessment of relative value, but our perception of gains and losses. And really, this is an unconscious process that underlies our decision making when we're making decisions under uncertainty. So another way of putting it is it's really a simple and official rule. It's mental shortcuts, these rules of thumb that we all come up with that are based on our case experience, our intuitive judgment, what we've recently seen. All of these things, when we follow this, we make these rules of thumb that allow us to do shortcuts to be more efficient with how we make choices. And no one knows this better than Chuck Norris. As far as the nature of heuristics, again, you can take a large amount of information and you can synthesize a more direct conclusion by drilling it down and following that rule of thumb. However, when you simplify and you distill it down, you're also dealing with all this noise that every one of us feels day to day. Home, things going on at home, things going on in the hospital. There's just a lot of input coming at us. So being able to distill this down and make choices is important to be able to move efficiently through the world. And the reliance on this strategy, however, when you start making rules of thumb, of course, is it leads to systemic and predictable errors in judgment. And those are what we are going to refer to as bias. Now, bias generally gets a bad name. I don't want to be called biased. I don't think any of us do. But bias simply means we all see the world from our own unique perspective. And it's based on our own beliefs, our desires, our personality, our past experiences, and the culture we all come from. And so, when we're using these heuristics and those are creating biases, we need that in order to make decisions and be efficient. And I think if I could emphasize anything as we go through this talk is heuristics and bias, it's not a flaw in our decision making, but rather it's an important feature that we all have. And the concept of prospect theory, and as we drill into the biases and heuristics, is to realize it's a descriptive theory of how we make choices. And the goal isn't to eliminate bias. The goal is to understand we have it, and the goal is to recognize it and to be able to work with it, both within ourselves, our colleagues, our patients, etc. So with all that being said, let's get into heuristics and biases a little bit. So this is an interesting question if you can just take a minute and read through it. So it breaks down a certain town is served by 2 hospitals. In the larger hospital, about 45 babies are born each day, and in the smaller hospital, 15 are born. As you know, 50% of all babies are boys. However, the exact percentage varies day to day. Sometimes it may be higher than 50%, sometimes lower. For a period of a year, each hospital recorded the days in which more than 60% of the babies born were boys. Which hospital do you think recorded more such days? And so just take a moment and think about it. Is it the larger hospital? Is it the smaller hospital? Is it about the same, within 5 percentage points of each? As you think about it, you're kind of trying to think, well, where's the where's the trap, where's the bias? But when you think about this from purely a probability standpoint, the answer is the smaller hospital. And the reason for that is the intuitive law of large numbers. And what that states is the more observation, the more that experiment tends to go to the average and to get close to the true proportion. So it's very easy, just in that one small example, to kind of start going down a certain path and then realize, there's a different level or maybe a more nuanced perspective to look at it. And when we look at the number of biases that are out there, there's more than 200 been described. And we're going to go through all of them. No. We are going to focus on just some of the more relative ones for medical providers. But it's important to realize that this is dipping our toe in the pool of some of these biases, and there's just a whole bunch out there to be aware of. So heuristics and biases as it pertains to us as medical providers. We make complex decisions, often in high-stakes environment. And we make these decisions based on our individual judgment, our hypothetical deductive reasoning, what us and our patients value, and our patient and our experience. And we put this all together to try and make the best decisions we can. And this is also impacted by the reality of working in the healthcare system such as it is. We have time constraints, large workloads. Oftentimes we don't have all the information we might wish that we had. Frequently, we're making these decisions under duress, particularly in an emergent type environment. And we don't always know how our experience and our patient's experience really influences us. If we have a very difficult experience with a particular procedure or a particular medication, wherever it is recently, that impacts how we might choose, regardless of what the statistics of that intervention may be. And I think this is also compounded, as nicely described in the Harvard Business Review, that many people in healthcare kind of fall under the general terminology of being a high achiever. And when you're a high achiever, we also have these other underlying traits that we might not have all of these, but we have some. Many of us have some of them, and these also are impacting how we look at our experiences. So we're not walking in, no matter what we all may think of ourselves, unbiased. We have all these things going on in us mentally. And I think, again, Danny Kahneman, who we'll be seeing a few times in this talk, just really made an excellent point, that the confidence people have in their beliefs is not a measure of the quality of evidence, but of the coherence of the story the mind has managed to construct. And he won a Nobel Prize for this. I think he's right on the money here, that oftentimes what we're touting as this is the right answer is more a function of what we believe and the coherence of that belief than it is on actual data. And so this leads us into this next question. If we look at this picture, can anyone, as you look at it at home on your computer screen, can you tell me which dot is the bigger dot? And the answer is they're both the same size. And this is called the Ebbinghaus illusion. And what it goes on to say is this is an anchoring bias. And by anchoring bias, when we have a data point, an initial data point, we use that as a reference point that subsequently influences all other decisions. And I'm going to dive in this just a little bit because I think it's important because it kind of illustrates some of the other biases that we have. So a classic experiment by Amos Tversky was exploring anchoring bias. And in this experiment, they had a wheel, imagine the Wheel of Fortune, with 100 numbers on it that was rigged to stop at either the number 10 or 65. They then asked subjects whether the percentage of African nations in the United Nations was greater or less than the number on the wheel. And then they asked a follow-up question, which is, estimate the correct number, the correct percentage of African nations. So those that spun 10, the guess was about 25%. Those that spun 65, their guess was 45%. And this was replicated numerous times by other studies that found have observed a similar finding. This is also seen recently, interestingly, in an article in The Economist. And in this example, this is a kind of self-experiment they did on their readers. They said, hey, we've got a deal. It's either $59 for an online subscription or $125. You get both the printed and the online subscription. When they said this, 32% did the 125. They wanted to say $59. And then they tried another scenario where they essentially added one more option where they said you could get the print subscription for $125 or you can get both for $125. And 84% then chose the $125 product. And what's interesting to point out, this is a kind of a self-experiment on people that subscribe to The Economist, theoretically people who might be aware and looking for this sort of thing. To take this same concept and drill it down for us in the hospital, here's a good example. Again, this is from an excellent book, Cognitive Errors and Diagnostic Mistakes, published a couple years ago. And so you have a patient in the hospital. with meningitis. There's a powerful new antibiotic that can cure this, but there's a serious risk of bleeding. Unfortunately, we had one fatality at Virginia Mason. Let's make this personal. The risk of bleeding can be determined by a genetic marker as either a high risk group or a low risk group. So the higher risk group, the risk of bleeding is 1 in 10. The low risk group, it's 1 in 100. Unfortunately, our patients in the high risk group, which one would you choose to give the antibiotic? Same question, but let's change it. The high risk group is 1 in 100. The low risk group is in 1 in 1,000. We have a high risk person. Would you give them the antibiotic? And having that comparison often can skew what decision we make. So anchoring bias kind of leads us down the road into what is known as the Weber-Fechner law, which states basically once that anchor is set, people are more strongly influenced by relative change than absolute change. So once you have that anchor set at 1 in 100 or whatever it may be, the change from that number, not the absolute change, is what we tend to keep our eyes on. And so a domestic example of this would be, let's say you're buying a $20,000 car. Would you drive across town, wade through Seattle traffic to get it for $19,900? And this is again from a paper published by Amos Tversky. Same example. You're buying a $200 pair of shoes. Would you wade through Seattle traffic if you could get them half off for $100? In the example of the car, 29% of people said, no, I'm going to drive across town. Yeah, I want to save $100. Same group of people, 68% of subjects said yes when they looked at it in the relative value, like half off a pair of shoes. And it's $100 either way. It's just interesting how we anchor to a particular number. It was $20,000 versus $200, and that influences how much that $100 might be worth to us. Another example of the Weber-Fechner law here is, as you look at this, this pictograph at home, I would ask you, between this one and this one, which has a greater number of dots? And between this one and this one, which has a greater number of dots? And in this example, it's pretty easy. You're like, wow, it's 10, I can see it's 10 more dots. On this side, it's much more difficult. And that just points out that the larger the magnitude of change is, the more that we're able to notice it and the more it influences how we make decisions. Not the absolute number, but the relative change. And so anchoring bias, Weber-Fechner law, leads to certain heuristics. And one of them is a representative heuristic. And that is we evaluate the probability of an event by evaluating how similar it is to events we've experienced in the past. And this leads to a famous term called the gambler's fallacy. And this is if an event is perceived to happen more often than is normal, it is presumed that event will happen less often in the future. You might have also heard this called the Monte Carlo fallacy. And that was named for an event that happened in the early 1900s at a casino in Monte Carlo where black came up 26 times in succession in roulette. People bet down again and again and again. Sunk costs, right? And at the end, the casino ended up making millions of francs because people could not accept the fact that you can't be black. It couldn't be black at 26th time, right? But each individual event has its own probability. Just because you rolled black before, there's nothing to do whether or not you're going to roll black again. So let's take that same concept and boil this down into a clinical situation. I'm not going to read this whole question, but essentially there's a 23-year-old woman who comes in acting off. She's having memory loss, personality changes, psychiatric symptoms, and she is, and her mother's insistent that she's being tested for limbic encephalitis and getting an MRI. And so the physician, and this is a actual vignette out of cognitive errors and decision and diagnostic mistakes. The physician at the time didn't get it, did not get the MRI. And when that physician was questioned, like, well, why didn't you get the MRI? She said, well, I'd already seen 2 cases of limbic encephalitis that month, and in her mind, this was rare. So I've seen 2 already. I'm not going to see a third, and it just seemed the odds were very low. And through that, she didn't want to be perceived as someone that was making that 1 in a million, that $1 million workup to find that 1 in a million event. But it doesn't matter if you'd seen 2 in a month or 10 in a month. the risk of that new person coming in having it is independent of how many we've seen. But mentally, when we've seen a bunch of things that are rare, it does tend to skew how we predict the next person coming in through the door. And this kind of comes into or falls into what we would call outcome or hindsight bias, which is the quality of the decision or action is evaluated after the result of that decision is known. In other words, she didn't do an MRI. You could say the quality of that decision was relatively poor because we know the outcome, but she didn't do an MRI. So what if the outcome had been positive? What if there hadn't been limbic encephalitis? It makes you wonder what is the right answer in that scenario? Was it getting the MRI or was it not? And that outcome, the right answer was you get the MRI. But does that mean that's necessarily the optimal choice? It's a difficult question. And so I think that Harvard Business School did a very nice job in an article they published in their review in 2009 defining outcome or hindsight bias. And that is the same behaviors produce more ethical condemnation when they happen to produce bad rather than good outcomes, even if those outcomes are determined by chance. And so, I'm a surgeon. An absolute tenet of surgery is blame it on anesthesia, of course. And I bring that up because there was a great study done by some of our wonderful anesthesia colleagues in JAMA a handful of years ago, where it was a study of 112 anesthesiologists. They were given 21 cases and asked to rate the appropriateness of each case in a patient that sustained either a temporary or permanent injury. And so when the injury severity was changed from temporary to permanent, it was determined that the appropriateness of that case fell by 31%. However, same injury, same scenario, when the injury was changed from permanent to temporary, the appropriateness went up by 28%. So the appropriateness should be independent of what the outcome is. It's just whether or not you have a positive outcome or a negative outcome skews how we interpret the appropriateness of a particular decision. And this leads us into the concept of biases, particularly the omission bias, which we'll talk about now, and the commission bias, which I'll touch on in just a moment here. So the omission bias, and that is we have a preference for inaction over action, with a tendency to judge harm as a result of an action more negatively than harm as a result of inaction. And this plays very heavily on us as physicians. And Predum non nocere, first, do no harm. It is a very tenet of who we are as a profession. And we really fall under the principle of non-malfeasance, which can lead to a moral dilemma. And this moral dilemma has been described over and over again. The first reference I saw in the published literature was a paper in 1967 by Foote and colleagues, and that's the trolley problem. And so it's trolleys steaming down the tracks, going at high speed. You've got a lever. You pull the lever one way, one person dies. You pull the lever the other way, 5 people die. Either way, someone's dying. So which one do you choose? And there's iterations of this very same problem where what if that one person was a family member? Or another example is you're standing over the bridge and there's a large individual. If you push that person over and kill them, you can save the people on the track. And what it really goes through, and it asks us over and over again, is what decisions do we make when we have 2 bad decisions? Do you choose to act? Do you choose not to act? And while this is a little bit of an obscure scenario, you could say, there's versions of this that can play out in things like transplant surgery. It's things that it's concepts that we say play out in our own lives as physicians, maybe in more subtle ways. And so let me just give you a couple examples. One is from the NBA, where in 2011 it was noted that referees call 50% fewer fouls in final moments of close games. They're hesitant. They don't want to make a mistake and be blamed for a bad outcome. So the number of fouls they call goes down. In a way, a foul should be a foul, no matter if it's the beginning of the game or the end of the game. But it's that omission bias that can help drive what decisions they're making. Another example, which I'm sure we are all very familiar with recently, is vaccination. And that is patients decide not to receive a vaccination because of potential chance of death, even when the probability of the vaccine will cause death is much less likely than death from the prevented disease. And that just comes right back to the omission bias. We have a tendency to judge harm as a result of action more negatively than harm as a result of inaction. And understanding that implicit bias gives us some insight into those that don't want to be vaccinated, and for people that need to interact with them and potentially counsel them on why they might want to choose it. It's an insight, or if nothing else, it's an empathetic way of looking at why people make some of the choices they make in this regard. And so if there's an omission bias, of course, there's a commission bias, which is a tendency towards action rather than inaction. Again, as providers, this plays on one of the tenets of our profession, benefits. And that's the obligation to do something for the patient, to help them. We feel this drive that we want to help them get better. And when doing too little hurts a patient, it impacts the physician's psyche more than doing an unnecessary test or maybe prescribing unnecessary medication. In other words, if a person is injured or has a bad outcome because we didn't act by not ordering something that we could have viewed as superfluous, that impacts us. And I think that a colleague of ours in the field of surgery who's heavily published and very well regarded in this regard, Atul Gawande, put it. He gives an example, and if you read through this clinical example, he gives an example of a patient that he saw in the emergency room. She presented with abdominal pain. He thought that it was more consistent with sexually transmitted disease, didn't order a CT of the abdomen. As it turned out, she had a carcerated bowel, turned gangrenous, required surgery. And he made a very interesting observation. And he states, by contrast, I can't remember anyone I sent for an unnecessary CT scan or operated on them for questionable reasons a decade ago. There's nothing less memorable. In other words, you'll remember the person that you didn't order the abdominal CT on, but it's really hard to remember however many people that you didn't order it on, that there was never a bad outcome. It is the quality it is the emotional tag or anchor that's attached to that decision that can really drive us in the next decisions we make as we move through our career. And another example, that was kind of an example touching on ordering questionably necessary imaging. Another example is overprescribing medications. And I think a great example, and I won't drill down too much on this one, it's been talked about plenty, I'm quite sure, is the opioid crisis. I mean, the patient bill of rights, the fifth vital sign. We need to treat these people's pain. And the interesting thing, accessing some of the data through the National Institutes of Health and the CDC, is from overtreating pain, 75% of heroin users reported they started with prescription opioids. And then also interestingly, and it's something that I keep in my mind as a surgeon, is prescription opioid use greater than 8 days increases the likelihood of opioid use a year later by 13%. And interestingly, prescription opioid use greater than 30 days increases the likelihood of opioid use a year later by 30%. And so, there are these decisions or these situations where we want to act and we want to make a difference or not treat someone's pain or whatever. And I realize that we've done a much better job about managing and addressing the opioid crisis. And the point isn't to just stand on the opioid crisis and say, look at this. The point is to more use it as an example, because there will be some opioid crisis like event or medication that comes up in the future, and maybe it might not be as severe, and maybe it might be in a different context. But understanding what helped drive that crisis, and I'm not saying this is the only driving factor, it certainly is not, but at least recognizing that might be a potential can be useful when the next version of this may arise in the future. And so all of this leads to the overconfidence bias. And this is one I'm sure we as providers have seen at various points throughout our career. And that is, providers' subjective confidence in their judgments is reliably greater than the objective accuracy of those judgments, especially when confidence is relatively high, leading to errors in judgment and decision making. And it's really predicated on three concepts or three pillars to overconfidence, if you want to stay. There's overestimation, which is a belief our performance is judgment is better than it actually is. There's overprecision, which is excessive confidence in our knowledge and that we get it right consistently, when if you looked at it systematically, we might get it right a fairly high percentage of the time, but certainly not every time. And then overplacement, which is when we overrate ourselves when we compare ourselves to our colleagues. And you can see when you put these biases together, there's a certain symbiosis, or there's a certain element in which they all circuitously are interrelated. In some ways, one leads to the other. So I'll give you just kind of a quick little run through. Commission bias. Somebody is sick. We act because we feel like that's the right thing to do. We can explain those risks by saying, oh, if you don't act, there's this chance of a bad outcome. So we anchor them to the bad outcome. We know people are risk averse and there's loss aversion. Now, this might not be conscious thought, but it starts in these unconscious parts of our mind. So we act based on that commission bias. Let's say that they have a good outcome. Now, that might be a good outcome with hindsight bias, but they have a good outcome. It happens frequently. Maybe not. Maybe they are, to use the relay example from the Monte Carlo fallacy, it happens 26 times in a row. And overconfidence bias is built. And this is all based around, again, coming back to the outcome bias. We're doing these things and we're quote unquote getting away with them. And these biases are interrelated, and in a way they feed each other. And a lot of it is going on subconsciously. And it's not to say that having subconscious thought processes is wrong, or that these biases in and of themselves are wrong. They're not. But it's the recognition of how they're systematically present that I think can be helpful for all of us, and has certainly been an underlying principle of behavioral economics. And traditional economics, just to touch on this again, traditional economics, we're assumed to be homo economicus. We make the rational decisions based on utility, on value. In behavioral economics, we're not rational human beings. We value gains and losses differently. We have heuristics which lead to biases. And I think while it's a simpler way, and it would be great if we could all be homo economicus, the reality is we're not. And so accepting that reality and kind of adjusting it to it accordingly is something that's worth considering. And so all these have been great concepts. I really thank everybody for their attention. To kind of wrap it up and put it all together, it's important to realize again, and I keep emphasizing it because I think it's something that bears repeating, is biases in and of themselves are not the problem, but they are driven by an interplay of our experience, our values, our culture, our desire to do no more harm or do no harm, or a desire to help people. All these things play into our decision-making process. Again, often under duress, and it's also playing into our patient's decision-making process. They are based on heuristics which are necessary to make efficient choices. We need these rules of thumb. They help us move through the world, but by using them, they create an unconscious bias that forms predictable errors or results in predictable errors. These decision-making features make us susceptible to predictable errors, as I just said, and there's a potential to use our recognition of these biases and heuristics to improve our clinical decision-making and improve how we interface with our patients. Again, how do we explain the risks and benefits of a particular intervention or treatment? What are we anchoring that person to? How does that influence whether or not they say yes or no to that? These are all things that we can be aware of that are unconscious largely, but recognizing them can influence potentially how we make our decisions. And I think that a very nice quote from this excellent book, Cognitive Errors and Diagnostic Mistakes, by Dr. Jonathan Howard, is having biases does not make us immoral or flawed. Biases make us human, and they're a result of those heuristics that we use to make decisions efficiently and inform our choices, inform our lives. Final points, take-home points, if you will. It's good. People carrying the house, little icon to wrap us all up. Again, we're not homo economicus, we're homo sapiens, and our decision making is not based solely on rational risk benefit assessment. It's all the things I've talked about ad nauseum. Prospect theory, if you can remember anything from it, it's a descriptive theory of decisions made under uncertainty, and that it's driven by loss aversion, sunk costs, as well as a variety of other factors. But particularly with loss aversion, it's important to realize that when we look at it systemically, boy, we like to have gains, but we hate to lose. And that's a big part of what can drive the decisions we make, or our patients may make. A heuristic, again, it's a rule of thumb. Chuck Norris showed us earlier. It's susceptible to predictable errors. And then biases. These result from an interplay of personal traits and experience. These are unconscious processes that aren't something that we can white knuckle and control, but rather they're something we can recognize and not necessarily eliminate, and hopefully use that information to drive better decisions. So I want to say thank you to everybody. I really appreciate all of our Zoom participants, and yeah, it was a real honor to be here this morning. Thank you. And any questions?
And we actually do have a first question in the chat. And just a reminder to everybody on Zoom, you can submit your questions for Dr. Varley in the chat. Our first question is from Dr. Andrew Friedman. He asks, as individuals, how do we improve our clinical decision rules to minimize error? It seems like biases actually help in making quick decisions. So, for instance, if you hear hoofbeats, it's probably a horse.
Excellent question and excellent point. I will tell you that there's a part 2 of this talk where I'm going to get into some of the strategies we might employ. But just to get into it a little bit deeper, the hoofbeats example couldn't be more perfect, because you're right, the hoofbeats, it's usually a horse. But there's another bias called the zebra retreat, which is where we run away from the hoofbeats because we're like, it can't be a zebra, it can't be a zebra, it can't be a zebra. And you're right, we do need to have these rules of thumb and these biases to make quick decisions efficiently, and they often do turn out well based on our experience. But the thing of it is trying to be aware of where our biases come in, and particularly when those biases can come to play at high stakes moments. In other words, if it's a person that gets, you say to drink 8 ounces of water and they drink 16, okay, great. That's not a very high risk outcome. But high risk outcomes for, invasive surgery, certain medications, et cetera, I think that's where those efficient heuristics and biases are important, and they help us make decisions, and they're not flaws, but recognizing them can help us avoid the zebra retreat. Because yeah, it's often a horse, but every now and then it's a zebra, and recognizing that can be a little bit of a challenge, and there are reasons for that come back to the material of this talk.
Great. And we have another comment from Dr. Hansen. It would be interesting to hear about how providers manage biases by working with other providers as a team.
Great point, and also something I'm putting together in part 2, but I think this is a very interesting question, and it really comes down to, we like to generalize that the wisdom of crowds, or that when we are in a team we make better decisions, and that can be true, but that doesn't necessarily mean it always is true. And I think a lot of what it comes down to, or not what I think, but what the literature, which I'm kind of eager to present next time, would show, is the quality of the team can largely determine whether or not it's groupthink or it's wisdom of crowds. And these are actually more statistical terms that I'll get into at another time. I was going to put it all in this talk, but it was just going to be too exhausting, I think, for everybody to listen to. But the quality of the team really can help drive whether or not that team is able to be a useful tool to recognize biases and heuristics and get closer to the truth, or if we fall into groupthink, or we have one dominant person in the team that drives what the other people think. So I think that having a team is very important, but I think being very honest with ourselves and recognizing that it is not just having the team, but the quality of the team and how we interact with each other that can really have an impact as to whether or not we recognize some of these biases and heuristics.
Great. And Dr. Louie says, very interesting topic, and certainly forces us to think about how we think and why we may think that way. Have you applied these principles to clinical practice from both the outpatient and surgical settings? How should we manage our biases?
Excellent question. And so to kind of circle back to the whole team thing, I feel particularly fortunate and blessed that I do have a team of people, other colleagues in our team, that I trust their opinion. And so one way that I manage my biases, which is another way that other people in our group manage their biases, is that we present our cases in front of a team of surgeons and non-operative specialists including our colleagues in PM&R and our other surgeons, and we say, hey, this is the case. Does this decision we're going to make sense? And that works because, people are willing to speak up and question. And so I think that's one way I manage my own biases. The other thing that I personally, if we're getting down to me purely as an individual, is if I have something come in and it comes into clinic and it's something where maybe it was a case I did, recently or a while ago, or something I saw as a resident where there's a particularly strong emotional reaction, either positive or negatively. Just being mindful and being aware of when your emotions are cued, when you're teed up, I think is really important. Because if I can sense like, man, I have this really good memory of this having a great outcome, or man, I can remember this one moment going really south, that emotion, that the intensity of that emotion can oftentimes be a trigger to realize that you're falling into a heuristic or a bias that's being influenced, not necessarily by data, but being influenced more by, your experience and your judgment and things like that.
So it looks like our next three questions are all around machine learning and AI.
Yes.
So I can read those out. Let me just read them out and you can
Sure.
apply them. So the first question is, what are your concerns for machine learning and its biases and its potential healthcare applications? Dr. Brandler asks, in an era of AI that can have its own systemic biases in the creation of the algorithms by humans, where do you see AI intersecting with this space? And Dr. Vasuvita, how do you think about the use of AI in medicine as it pertains to helping minimize bias?
Man, I feel very lucky to be
Same time.
to be working here, because you guys are all asking the very questions of kind of what I'm putting together for the next talk, and it's a great question. And if we're going to be honest, nobody really knows exactly how AI and machine learning is going to exactly evolve. But let me just tackle these questions. I did reference what was considered a pretty strong AI paper or machine learning paper in the space of surgical decision making. And so my concerns for machine learning and potential in healthcare, the concerns are that if we hack our biases into machine learning or AI, we are going to have it spit back out at us in the same format. And what I mean by that, let me just drill down on that a little bit more. I think it is great, and I'll call it spine surgery. We have a lot of wonderful thought leaders, and oftentimes when we go to these meetings or we go to, this is the next revolution in whatever part of spine surgery, implant design, or let's say this case, AI, it's oftentimes a lot of the same key opinion leaders or key opinion leaders that share very, very similar thought processes, which is great. They're key opinion leaders. We want these people out there helping drive it. But the problem of it is when you have people that have a very similar perspective, that are oftentimes representative of perhaps a very particular age. I'm on the younger side of the equation. They might be on the older side of the equation. And so when you have a group of people that are helping build AI or are contributing disproportionately to how it's being constructed, I think that we can run into the problem that we will see the biases of those key opinion leaders, of those people that are overrepresentative in machine learning, perhaps. It might be the centers that submit more data for machine learning, whatever it is. I think that we just have to be aware of how that machine learning and how that AI is being developed, and recognize that even when you take in any given field, the best of the best or the key opinion leaders or whatever, when you cluster them together, there are strengths. But again, a bias isn't a flaw in the system. It's just how we are. I think that those biases will be generated, and it's going to require a lot of thought on our part and how to manage those. And then just one quick follow-up thought on that is, I think one other thing that we've got to recognize is, will we as a profession be willing to embrace or accept AI? And I'm not necessarily talking purely here at Virginia Mason in in a tertiary or quaternary care center where people might be a little more open, or maybe they're not, but I'm saying in medicine in general. And, I can only speak to spine surgery, where we've had some concepts looking at alignment of the spine relative to the pelvis and some other things that have been really we've kicked the tires on a few of these concepts over the years. And while there are nuances to them and there's evolution, certain principles have been shown to be pretty useful. But having been out in the community, a lot of people don't want to, other providers don't want to embrace this because it argues with their own biases, right? So we might come up with the ultimate AI for the clinical decision making in, you know, prostate cancer or whatever it is, right? And it might be something where we have a key opinion leaders, but then it's tested by other groups, and we come up with this really useful tool that has the potential to help a lot of people by recognizing our bias. The problem of it is we might get there, but we might arrive at a moment where the people out in the community don't embrace it because we're offering them this thing, and we're when we're bringing it to them, we're punching their bias over and over and over again. Like, look at this. This is going to make you better. You need to do this. Like, not doing this makes you less of a surgeon or whatever. Like, there's subtle ways that these things can be advertised as community physicians, which can be really hard, and advertised to us. I'm not just picking on community docs or just picking on us. I think that even if we develop something really powerful in this way, and there's a whole bunch of hurdles to that, we still have to see how do we actually get it to be embraced by enough people that we can really have an impact on our healthcare system writ large, not just at certain centers, not at just certain places in the country, but really in a broader context. Man, great questions.
Thank you. And I think we just have this last comment that I think everyone would echo. Really great talk.
No, thank you all, and thank you all for being here. It truly is, just a wonderful place to be, and I appreciate that everyone spent some of their morning with me, and thank you all for being here. Much appreciated.
Great. Thank you so much. This concludes our Grand Round session.